Okay. Good afternoon, everyone. Okay, we welcome the community to today's presentation that's titled Long COVID-19 and Rheumatology. Okay, I'm Dr. Chikuluma, and I will be your facilitator for today. And today's presenter is Dr. Kunda Yumbe. I'll allow her to introduce herself.
Good day, everybody. Thank you very much for inviting me. I have been a beneficiary of the MOH ECHO information sharing platforms without really knowing much of what community to share.
Sorry. So we had a slight glitch in our presentation. I'll allow Dr. Yumbe just to introduce herself. We were on mute the time that you were introducing yourself.
Good day. My name is Kunda Yumbe. I'm a doctor at the Adult Hospital, UTH, with the Department of Internal Medicine focused on rheumatology.
So just a reminder on housekeeping rules, we allow the participants just to mute themselves. And as the presentation goes on, we allow that as you're about to speak, you unmute yourself and introduce yourself. So at this particular point, we ask Grace to kindly mute. Okay. All right, thank you. All right, so today's objectives are mainly three. We're going to be discussing the epidemiology of long COVID-19 and also discuss the common rheumatological manifestations of long COVID and also the approach to the management of rheumatological disease in long COVID. But before we delve into the discussion, we'll give some questions to the community so that they can at least gauge the information that they have, and we see the learning outcomes that will take place at the end of today's session. So we'll run the polls just now. And our first poll reads as follows. Okay. Which of the following is true about long COVID? So you're allowed to pick as many answers as possible, but ideally this is a single best answer. Therefore, the option A reads only affects the lungs. B, only presents with psychiatric conditions. C, only presents with a persistent cough. D, it is a multi-systemic presentation. So we'll give about 30 seconds to the community to give us their answers. I'll repeat the question. Which of the following is true about long COVID? A, only affects the lungs. B, okay. I can't read. All right, so I'll go through the options. Only affects the lungs. B, only affects, only presents with psychiatric conditions. C, only affects, only presents with a persistent cough. And D, it is a multi-systemic presentation. So our 30 seconds is over, and we're ending the poll. And just a recap on the selections. Dr. Yumbe, we have 100% of the community picking D, saying it is a multi-systemic presentation. Okay, we'll move on to the next poll. So poll number 2 reads, okay. Poll number 2 reads, in which of the following groups of symptoms describe the most common symptoms of long COVID? So we have A, having seizures, blindness, loss of hearing. B, fatigue, dyspnea, confusion. C, diarrhea, vomiting, blood-stained stools. D, urine incontinence, pain on urination, and bloody urine. So you're allowed to pick your question, your best answer. And I'll repeat the question again. So the question reads, which of the following groups of symptoms describe the most common symptoms of long COVID? A, seizures, blindness, loss of hearing. B, fatigue, dyspnea, confusion. C, diarrhea, vomiting, blood-stained stools. D, urine incontinence, pain on urination, and blood in urine. Okay. So we have a few more seconds to give chance to the other participants. So feel free. Your answer, the pick that you choose is a secret, and will not be revealing who picked which of the options. Okay. So our 5 seconds is up. So just a recap on the selection. We have 100% of the community responding to the poll, and all the participants have actually picked B, saying the most common group of symptoms that present in long COVID are fatigue, dyspnea, and confusion. We'll move on to our third poll. So our third poll is a true or false question, and this one will give it 10 seconds. Okay. So the question reads, males are at a higher risk of developing new rheumatic autoimmune diseases in long COVID than females. I'll repeat, males are at a higher risk of developing new rheumatic diseases in long COVID than females. So pick, is it true or is it false? Okay. We have 3 more seconds to ending the poll. So we encourage the community to pick their best answer. All right, and we have 71% of the community responding, and the community says B is the answer, that it is false. Okay, we'll move on to our fourth poll. So our fourth poll reads, which of the following is a rheumatic autoimmune disease that can develop during long COVID? I'll repeat. Which of the following is a rheumatic autoimmune disease that can develop during long COVID? A, vasculitis. B, reactive arthritis. C, spondyloarthropathy. D, all of the above. So we'll give it some 20 seconds for the community to respond. I'll repeat the question. Okay. Which of the following is a rheumatic autoimmune disease that can develop during long COVID? A, vasculitis. B, reactive arthritis. C, spondyloarthropathy. And D, all of the above. Okay, so we have 5 more seconds to ending the poll. And we have 66% of the poll giving us their best answer. And the distribution of the answers is that 50% have picked reactive arthritis and 50% have picked all of the above. Okay. We'll move on to our fifth poll. All right, and the question reads, which of the following is a risk factor for the development of fibromyalgia syndrome? Which of the following is a risk factor for the development of fibromyalgia syndrome? A, female sex. B, physical activity. C, obesity. D, all of the above. So pick your best answer, and we'll give it some 20 seconds for the community to respond. Okay, do you feel being of female sex puts you at risk of developing fibromyalgia syndrome? Or is it physical? Sorry, this is a typo. It's supposed to be physical inactivity. So being physically inactive, will it put you at risk of developing fibromyalgia syndrome? Will obesity put you at risk of developing fibromyalgia syndrome? Or are you saying all of the above options will put you at risk? Okay, we'll end the poll. And we have 71% of the community responding. And the distribution is as follows. 40% have picked female sex being the risk factor, and they've also picked all of the above as their second best option. And the other one is physical inactivity. We'll move on to our second last poll, which is the 60th. Okay. And it reads, which of the following tests can be used for screening of rheumatologic autoimmune diseases in long COVID? Which of the following tests can be used for the screening of rheumatologic autoimmune diseases in long COVID? A, TSH with free T4, B, APS serology, and that is C, tissue or muscle biopsy, D, a myositis panel. So pick your best answer that describes a tool that can be used, a test that can be done whilst you're screening for a rheumatologic autoimmune disease. Will you request for a TSH free T4? Are you going to request for APS serology, or will you request a tissue or muscle biopsy? Or lastly, are you going to request for a myositis panel? We'll give it some extra 10 seconds for the community to respond. We are at 50% of the community giving us a response to this question. And in the next 5 seconds, we shall be ending the poll. Okay, so feel free to pick your best answer. Okay, all right. So the answers are as follows. We have 75% of the respondents picking APS serology and 25% of the community picking a tissue or muscle biopsy. We move on quickly to our last poll, being the 7th poll, and it reads, okay. Which of the following is not a non-pharmacological management of FMS, which is fibromyalgia syndrome, and CFS, known as chronic fatigue syndrome? A, okay. We'll repeat the poll. We had a glitch in our system. So I'll give it a few more seconds just to save on time. All right. So we have, which of the following is not a non-pharmacological management of fibromyalgia syndrome or chronic fatigue syndrome? A, acupuncture, B, paracetamol, C, vitamin D, and E, exercise. Which of the following do you feel is the best in response to the question of which of the following options is not a pharmacological management? So essentially what the question is describing is which of the following is not a non-pharmacological option in the management of FMS and CFS. So encourage the community to give us their best option between A, B, C, and D. Okay. All right. So it appears our community has decided to not respond to this one, which is okay. We shall eventually explain what FMS and CFS is, in case in our practice we've not yet come across it. All right. Thank you very much for your participation. And we move on into the presentation. Dr. Yumbe, the floor is yours.
Thank you. Thank you for that, Paul. At first glance, it may look like issues that are unfamiliar, but as we delve into them, it will become clear that most of these terminologies are things which you are living with on a daily basis, either as somebody who has been through it or somebody who is treating people who are currently going through it. Before I go into long COVID, let me say a word or two about rheumatology, because the question is, why rheumatology? And I'm sure there are people here who are not quite clear as to what it is. Rheumatology is a branch of medicine that deals with the musculoskeletal system, in essence. That is the bones, the joints, the muscles, and it also deals with autoimmune diseases. So rheumatology is, when we're talking about specialist referral, we see that people are saying they're referring people to the cardiologist, they're referring people to pulmonology, they're referring people to 1, 2, 3, 4, 5, and other. So now what is this other? Amongst the others, is rheumatology, because it's a branch of internal medicine that deals with things that people are suffering with every day. So the background of why rheumatology is because rheumatology deals with multi-systemic problems, and long COVID is also a multi-systemic problems. So the problems of long COVID are still unfolding, and the knowledge about it is still being added to. And for the beginning, we thought this may be potentially debilitating, and it's also raised concerns about whether these functional impairments are temporary or whether they will be with people for a long time to come. So because long COVID patients have a disease which comes and goes, or a disease which can be continuous, which is relapsing and remitting, they complain about being tired, feeling breathless, having a cough which doesn't quite pass, bone problems, pains in the muscles, pains in the joints, not sleeping well at night, having difficulties with their memory. And these are the exact same issues that rheumatology has been dealing with in the past. And now we are beginning to see a very similar picture when we look at long COVID. So due to the shared clinical features, due to some lab tests which are similar between rheumatology and long COVID has a tendency of mimicking a lot of things that we have already been seeing in rheumatology. And so the diagnosis can be a challenge. Yeah. So this is just to say that a lot of research has gone into looking at the symptoms of people with long COVID. And so we have to remember, as rheumatologists and as general practitioners and as healthcare workers, seeing our patients at various levels, that if somebody comes in with musculoskeletal complaints, I've got joint ache, I've got backache, I've got muscle pains, muscle aches, we should know that long COVID is a differential diagnosis that we have to think about. And because of this, rheumatologists might play a crucial role in identifying long COVID cases earlier, because we tend to see the people complaining about musculoskeletal problems earlier. We can also perhaps contribute to research. Yeah. So what are the things that put a person at risk of developing long COVID? It has been noticed that 7 people in the population are more likely to have it than others. So we see it more in women. We're seeing it more in people who are older and going into the elderly. We see it with people who are overweight, who may be suffering from problems of being overweight, because people who carry extra weight often have pain in the knees, pain in the hips, complain about lower backache. In our diabetics, in our hypertensives, in some people who had things like asthma. Now, the big group of people who are on immunosuppressed for one reason or another, then the people who had quite severe COVID at the time that it was happening and were known to have had more than 5 symptoms, then the people whose COVID virus levels in their blood and body were very high at the time of the illness, then not every patient manages to clear the virus very fast, which is what we used to see with other viruses. You can have the flu for a short time, it passes, it finishes, but there are some COVID patients who still have persistent infection with actively reproducing virus even afterwards. Then the last group, which is very much a factor, are people who have had other infections, other viral infections, which then get reactivated and kind of feed into this long COVID clinical picture. Yeah. So this is also talking about the risk factors just in images. So I won't go into what's above, But I just wanted to say that apart from risks, we also have protection, and some level of protection against developing long COVID can be offered by being vaccinated, because we see it less frequently amongst populations with higher vaccination, and can also be there amongst people who received treatment. Now, at the beginning of the pandemic, there was no treatment, but as treatment develops and becomes more targeted, those people who receive active treatment are less likely to end up developing long COVID. Yeah. So this is just to say, how much COVID do we have in the world? Amongst most countries, when we come and put everybody together, we find that most populations have between 6 to 15% of the population developing long COVID. So now the next thing is to talk about how we came to this percentage, that a study was done, which included a lot of studies, 54, and 2 medical record databases, and included information which came from 22 different countries, checking at 3 months after the initial acute COVID, and they found that 6.2% of patients still had symptoms or had developed symptoms. So from here, the thinking started focusing on what symptoms were they seeing, which were either not finishing or they were still present. And one of them was just feeling tired. The second thing was memory problems, being forgetful. The third thing was to do with the chest and with breathing. This is to continue and saying other places that we have been getting information for. This is now looking at the pandemic in 2024, because the original things were at the very beginning, 2020, 2021, when we started. And we find that it's still around 7% in America, according to the Medical Expenditure Panel survey. And then according to other electronic records, they found that out of the outpatients who were coming to the various medical facilities, 15% still had at least one long COVID symptom at 12 to 20 weeks after infection. Now, if we compare that to other diseases, it would be only about 2.9% of people who did not have COVID and had come to the clinic for other problems who still had symptoms. So that's a real big increase compared to other diseases. Now, in Africa, what is the situation? The amount of information we're getting is not always complete, but a group looked at 14 different studies from 7 different African countries to see what were the initial outcomes. Altogether, they looked at over 6,030 patients who had had acute COVID, and they also looked at 2,954 patients who had had long COVID. And why did they do this? Because they wanted to see what are the most common symptoms, what are the other diseases these people had, and to try to get whether there are any differences in our African population. So when they looked at how commonly it was being found, they found that it had a pooled prevalence of 41%. So in different areas, it could be from 26% to 56%, which is kind of like what they found also in other areas outside Africa. But in Africa, most of the common symptoms were actually higher than they were in other areas. So the fatigue, people just feeling tired, the breathlessness sensation, which was not settling, confusion or lack of concentration continues to be a problem. So the other thing that they noticed is that part of the African population also had problems with clotting and having blood clots form, whether in the legs or in the chest, more than what had been noticed in populations outside Africa. Yeah. So let me say a word or two about the early Zambian experience. So this is coming from the PAC clinics, which were mentioned in an earlier presentation. So yes, I have the audacity to start talking to the people who are actually doing the clinics about what rheumatology has found in the information that they get. Now, this is just to say that every patient who came to these uh, post-acute COVID clinics would have a lot of information collected. They talk about the patient's demographics, the medical history, what other illnesses they may have had. And all of this information was being put into standardized forms. So examinations were done as they are in doctor's visits, lab investigations were done. The patient's mental health was checked, functional health was checked. So this actually gives us a lot of information about what was happening to the initial idea of long COVID, and patients who were developing other things were being referred to other medical subspecialties. Yeah. So now this is a graph which I briefly just want you to have the idea of what happened with our COVID acute pandemic, because the post-acute COVID clinics, when they started, and let me take a moment to say how the Ministry of Health was pretty fast in recognizing that COVID, unlike a lot of other viral illnesses, was not disappearing. So as early as 2020, going into 2021, this was being followed up. So this is just showing us the different types of COVID viruses that we had and the number of people who were attending clinics. Now, the reason I feel this is important is that if you look at 2021, which was the peak of the Delta wave, where the word Delta even went into the general population, you see that we had so many acute cases. So the obvious thing is after the acute cases, we started seeing more and more people coming to various medical facilities with complaints which were just not going away. Next slide. Now, this also looks like a lot of information, again, courtesy of the post-acute COVID clinics. But what I wanted you to see is that the different symptoms on the side, the cough, the fatigue, the shortness of breath, chest pain, heart palpitations, and all of these things which you have been complaining about and you have been feeling were actually being quantified to say how many people are having it. Now, the only thing I want as a takeaway from this busy looking slide is that when it comes to most of the things, if you look at the overall frequency at visit number 1, because there would be subsequent visits, visit number 2, 3, 4, up to 5. And this would be at the clinician would decide if a patient needed to be seen again. But if you look at visit number 1, then you see that most of the things are actually getting better by the time we get to column number 5. So there was a significant number of people who were improving after COVID, because when we're talking about long COVID, we may forget that most people do actually get better. But if you look at the second bottom column, which says muscle aches, then you see that the first visit literally had fewer, 5.2%, than the fifth visit, where we are seeing 8%. So this was one of the early signs to say that instead of this disease finishing and patients feeling better, a certain part of the population was actually beginning to get worse 2 months after the initial problem. So the question arose, why? Yeah. So this is something similar. It was a questionnaire that would be given to the patients who came to the COVID clinic. So I just want you to look at the first part of it, because I know that I often have complaints from my patients, the rheumatology patients, to say, doctors never talk. to their patients. But you can see from the questions about these questionnaires were filled in before the patient actually went into the doctor's room. So we talk about walking long distances, the day-to-day work at school, whether a patient was able to stand for more than 30 minutes, how they were managing to do their household tasks, washing their body, concentrating for 10 minutes, whether they were sleeping well at night, how they were getting dressed, whether it was they needed help with getting dressed in the morning, the ability to care for themselves, and how they found their moves. So this is just to say that as medical people, we're actually very interested to know what our patients are suffering even outside our facility. And in rheumatology, it actually belongs to part of the questions we ask to find out. And this is a lesson from rheumatology to other medical professions to say that it gives us a very clear picture of whether we're making progress or not. The last thing I would want to say on this slide is that if you look at the lighter version on the right, you will see that most of the big numbers on the left are people getting better. They're all getting better, 76%, 70% what. But on the right side, we still have people who are either not getting better or they were actually getting worse on every one of those things. So some after COVID could walk, then later they couldn't. Some were independently doing everything in their houses, and then later they couldn't. So again, the question arose, if this is up to 2 months after your acute episode, why would you be getting worse instead of getting better? Yeah. So this is just to say, we're looking at which symptoms are commonly being seen in patients who have long COVID. So in this particular study, they looked at 1,276 patients who were hospitalized with COVID. Now, just so that, because we talked about the world, and when we said the world, it was USA, this study was done in China, actually in Wuhan, because Wuhan started seeing long COVID, obviously, before the rest of the world started seeing long COVID, because their epidemic was a little bit advanced, because that's the place where acute COVID first started. So they looked at all of these hospitalized people who had been hospitalized for acute COVID. After they were discharged, they followed them up at 6 months and they followed them up again at 12 months. And from then, they made a list of the people they had checked. 53% of them were men, with the average age being 59 years. What were they complaining about? What were they suffering from? So the percentages are on the side. These were people who complained about fatigue and feeling tired, and women were more likely to complain about that, and people who had had certain treatments were more likely to complain about that. Then they were complaining about sleep disturbance. That's almost 1 in 4, 1 in 5. A quarter of the people couldn't sleep well. Some people lost their hair. Some people had joint pains. Some people had skin rashes. And some people had muscle aches. That's the myalgia. And all of these complaints are complaints which we used to see in rheumatology even a long time before we had the acute COVID episode. But now we started seeing more and more people complaining of these things. It's fine. Yeah. So this is again a second study. So this time they were looking at people who were not hospitalized, because the first study had looked at people who had been so sick that they were in hospital. Now the question we want to ask is it only the people who are very, very sick who are going to end up having long COVID? Or can we also see long COVID in somebody who was never very sick at the original time of the COVID? So they looked at people who had not had serious COVID, and they looked at 3,762 people, and they found that in this population, because it was done by survey. So I think there's a bit of a bias of the people who actually answered those surveys. Out of this population, almost 80% were women, and most of them were white ladies aged from 30 to 60. But the interesting thing from this particular study is that even the people who were not tested at the time they had COVID, because we never managed to test everybody, still had very similar findings and symptoms to the people who were there before. And for rheumatology, the other interesting thing was we were seeing men and women, because most of our autoimmune diseases, we tend to see more women than we do men. This time it was equal. Yeah. So what were the clinical characteristics? So basically, there were three big groups. In the group one, these are people who had long COVID and they had a lot of symptoms, and the symptoms were finishing as they moved. Group two are people who had symptoms which were not finishing, but they were more or less the same throughout. Then group three had actually new problems and new symptoms which started appearing later in the disease course. So we find that a lot of the musculoskeletal problems we see in rheumatology were just there throughout. They were there from the very beginning, but because patients were bedridden or hospitalized, they did not notice them much, and they were there months and now years afterwards. Again, the most frequent symptoms which go beyond 6 months are people getting tired or feeling tired all the time, waking up tired. Then post-exertional malaise is after they just move around or do something small, they feel very, very tired. Then the cognitive dysfunction is the memory, the lapsing, the not remembering. Those are still there 6 months down the line. People who have long COVID find that if they take part in any of these activities, it tends to trigger them feeling bad. Some people, it's the physical activity, certain stresses, exercising, mental activity even. And for some ladies, they find that they suffer around the time of their periods. So the reason this picture is there, it's supposed to be a human being, even though it's looking like a ghost. Is that I want you to see that there's so many different symptoms which we're going to have in our long COVID patient. So the take-home message of this slide is to know that we need to ask about the head, the mouth, the muscles, the heart, the GI tract, the brain, the skin, the lungs, the kidneys, the abdomen. And if you look at that, out of all of the complaints, people are not going to have everything, but they will have something or nothing. Now, keeping in mind that they might have brain fog, so you need to actually actively ask them, otherwise they might forget to tell you. Now here, I just wanted you to look specifically at the different types of long COVID symptoms. On the left side of the slide, we're looking at joint pain. That's a whole slice out of the pie chart. On the right side, above, we're looking at fatigue. So just the joint pains and fatigue, that is already a significant part of the symptom complex of long COVID. And this is a reason why a lot of long COVID patients end up in our rheumatology clinics. So of the presentations which we were looking at that image, the one I'm focusing on now is what is outlined as myalgic encephalomyelitis and chronic fatigue syndrome. So we shall go into that more. The second one I'm looking at is fibromyalgia. We shall go into that more. Yeah. So what is myalgic encephalomyelitis? What is chronic fatigue syndrome? So this is when our patients come to us and they just say, "Doctor, I am tired of being tired because I'm tired all the time. I'm tired without explanation. I wake up tired, I go to sleep tired." So this is substantial reduction in their ability to perform things which they could do before without any problem. And suddenly they're not managing. for 3 months or more. Before we used to have 6 months. I don't know how sadistic those doctors were who were waiting for 6 months before they decide that a person needed a diagnosis. We are less sadistic now. So the new guidelines say 3 months. If this has gone on for 3 months, either it's associated with new onset fatigue, especially post-exertional. Again, this is not just being tired. This is somebody who does a little bit of work and physically cannot manage to do just housework and cannot remember the little bit of work they do. Suddenly their memory is bad, they've gone back. Emotionally, they cannot tolerate doing what they used to manage to do before. They experience a worsening of symptoms. Then the second event is when they sleep, they don't feel rested. The third thing is the mental part. Orthostatic intolerance means that you might find somebody is falling down or fainting. If they stand up suddenly, they get unbalanced or dizzy. So to summarize all these 3 symptoms, it's just tired, 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 sleeping but not getting rested, and mentally just not myself. That's what our patients tell us. And next slide. So we quantify that. So all of this is just to say, we have to quantify it. The second disease I'm talking about is fibromyalgia. Again, a big word to describe something which our patients have actually been describing to us. And the difference here is that there is pain. So in the other one, I was talking just about being tired. In this one, the number 1 complaint is pain. I'm just feeling my whole body. You say points to where you're feeling it there. It's here, and I can't say one place. I'm having pain on my back and over my arms and over my shoulders and in my head and in my legs. And then some people, when they go to the clinic, they're told, how can somebody be having pain everywhere? So this is hysteria. This is something else. But in actual fact, it's a real thing. So if symptoms have been present at a similar level for 3 months or more, then we can say that this is fibromyalgia syndrome, FMS. A syndrome in medicine just means you've got symptoms and symptoms and symptoms which are not quite fitting into any other disease. But because we hear them from our patients, we believe our patients, we know that this is a real thing, but before, it was difficult to have a diagnosis for somebody who is just in pain. So the next slide is just to show you that we try to quantify it. We will literally be checking where the pain is, and as time goes on, we'll check again, time goes on, we'll check again, and we'll try to keep a record of, is it getting worse, is it getting better? So you can imagine this is something we're now seeing with some long COVID patients where they just have pain everywhere. So the word for that is fibromyalgia. When there is no actual physical, there's no actual physical substrate that is explaining why this person is having pain. So the fibromyalgia syndrome, it results from a disturbance in the way the brain is understanding pain. So somebody has pain on the leg, on the arm, on the back. We've checked the arm, it's nothing. We've checked the back, there's nothing. We're checking physically. All of the tests have come back and they're all normal, 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 normal. But the patient is still in pain. So a lot of our patients we see in rheumatology clinic have been going from clinic to clinic, hospital to hospital, trying to get a diagnosis. If you have a patient or you have a family member who is just in pain, the core criteria being widespread generalized pain, and they're tired all the time, they're tired early morning, and this has been going on for more than 3 months, then consider fibromyalgia. Yeah. So now I'd like to just spend some time talking about what are the things we're seeing in long COVID as rheumatologists. So the title on above goes new onset autoimmune disease as part of the post-COVID syndrome. Now this new onset means that they didn't have it before, they got COVID, the COVID seems to be going down, and now suddenly there's a new disease. So the rest of this is to explain what we find on lab investigations. So when we have all of these cases, there have been some studies which have been done to try to quantify it. And this is one of the studies which was done in 2019 to 2021. And those were the findings. Next page. Abracadabra. Yeah. So because we were talking about autoimmune diseases and rheumatology diseases, these are the subtypes of diseases which we're finding in patients with long COVID. Vasculitis means your blood vessels are affected. And sometimes a person can look like they've got a rash or they've got spots or they've got what. We even have patients who people are scared of because they look like they've got some infectious disease. Meanwhile, the infection of long COVID finished a long time ago, and now they appear with blood vessel problems, the vasculitis. Sometimes they have joint pain and joint problems. That's the reactive arthritis. Now, this is the word which appeared in one of our poll questions, and I could hear somebody going, Malengwinter. Spondyloarthropathy. Again, it's just a kind of arthritis which affects primarily the joints that carry the body. That means it will be the back. And it's one of the few arthritises that affects mainly men. So this will be somebody who will have backache, backache, backache. Then the back will become very stiff. And if you have seen people, elderly people who look like a number 7, they're bent over, that's probably the same spondyloarthropathy. And this can develop after COVID. Okay. We've also seen muscle problems, inflammatory myopathies, where someone is in pain. Literally, the muscles are inflamed, they're leaking enzymes, which are the things we test. We've seen rheumatoid arthritis, we've seen systemic lupus erythematosus. All of these affect joints and affect muscles. Okay, these are some of the more rare conditions which I won't go into at this point. The screening, which was also one of the poll questions, I don't know the sadistic poller that we have. The first part of it is the part that's really important, to screen and be able to refer people to the necessary doctors. So those are the tests we do as screening tests to rule out, because we know that a patient who has thyroid problems can have muscle aches. We know that a person who has muscle problems can have muscle aches. We know that even with malaria or with flu or with any other problem, somebody can have muscle aches. So these are the tests that help us decide if this person needs to be referred or not. The second group of tests are probably going to be done with the help of a rheumatologist. Now, to the being tired, I just wanted to say that the important thing is how to approach it. So somebody must really, really think about resting, sleeping, and managing fatigue. We call it the 4 Ps. You plan. Even if you need to go for a hospital visit, do not plan 3 activities into the same day. You pace. If you do one thing on that day, do not plan to do 5 other different things. You have to prioritize what is more important and position yourself so that you're not getting yourself overly tired all the time. The musculoskeletal approach is treated by doctors. Usually it's just aspirin or Panadol, and people will be like, that doctor doesn't know what they're doing, or that hospital, they don't know what they're doing. But that is the correct way of treating muscle aches if there is no underlying pathology. However, if you notice that there are new symptoms or the symptoms are getting worse, or a joint has become big, swollen, inflamed, red, then you need to test more and refer. Now, the non-pharmacologic therapies, I've put a whole list of them. The reason this slide is included is because in fibromyalgia and in chronic fatigue syndrome, these non-pharmacological therapies are actually the thing that brings the most benefits. And this is unusual for us as clinicians to be thinking of things like cognitive behavioral therapy, to be thinking of physiotherapy. to be thinking of somebody exercising, to spend time talking to people, to refer them to psychiatrists, psychologists. UTH now has psychologists. So the numbers of people we have to deal with our patient population has increased. We used to have very few psychiatrists. This is so, so important. I cannot overemphasize how important it is to do other things for people who have long COVID, apart from just hand them a prescription. The pharmacologic therapy is what the doctors will be doing. On this point, I just need to emphasize that opioids and NSAIDs usually are not helpful for fibromyalgia. We have worldwide in some countries opioid pandemics. We are not in the habit of giving people who have long-term pain things like morphine, because in this situation, it's actually not helpful. Okay. So then I'd like to talk about vaccination, because we know that it prevents acute cases. We still want to see if it's going to prevent also long COVID. Early in data seems to indicate that people who are vaccinated do have some protection against the long COVID. These, I'm calling them investigational therapies because that's what is being used. I'd like to talk about the second one, though, the Paxlovid, because it is something which actually is an antiviral, and if used early enough in the acute COVID stage, does seem to lead to people less likely to develop long COVID. But most of this is just by observation. Big studies are yet to be done. The last thing I wanted to say is to remind everybody to proactively look at our patient population and think about the comorbidities, think about patients who are already on immunosuppressive drugs, think about women of childbearing age before we prescribe a medication that may do damage to a child, to think of our elderly patients who already have 5 different medications and they're already confused about the medicines they're taking. And now they've got this brain fog, and we start adding more and more and more medication. And to think about our adolescents, sometimes we have a 10-year-old who's been on the same dose and now they're 18, still on the same doses. With any long-term disease, we have to consider these things. Okay, these references. So in short, the approach to our patient is very person-specific. It is not a universal one-size-fits-all type of approach, because the success of our intervention really depends on making a connection with that patient, recognizing who needs help, linking them to other relatives or community workers or what, to make sure they keep on taking their information. So it goes beyond what happens at the hospital. Thank you very much.
All right. Thank you very much, Dr. Yumbe, for this wonderful presentation. I believe we can all agree that a combination of rheumatological diseases and long COVID appears to be a very puzzling topic, but today it has been dissected nicely, and we should be able to have a dual approach in terms of seeing patients that have long COVID and those that we suspect to have rheumatological conditions. So thank you very much. And before we get into the next segment, I just want to take this time to apologize to the network that we may be running short of time. However, we'll get into a discussion to engage with the community. So when you have a question or you have a contribution, just raise your hand and we'll be able to pick and allow you to unmute. And thereafter, you have to introduce yourself and then go ahead with answering with making your comment. And I must also say that we are joined with a number of doctors that have been involved in the management of patients who have had long COVID and looking after them thereafter. And we have Dr. Neil Naik, we have Dr. Kabaso, we have Dr. Tepa, and we also have Dr. Wadiambulo and Dr. Danielle. Dr. Foloshi is also with us, and feel free to ask questions that can be directed to any of them. They are more than happy to give feedback. All right, so we have Jackson. Please go ahead and unmute yourself, introduce yourself as well, and proceed with your comment or question.
Okay, thank you, Tim. That was a very profound presentation. I'm Jackson Mwadix, Technical Standard Action HIV USID. Yeah, I just wanted to find out on the presentation, the presenter actually highlighted in the poll that women actually have higher risk of developing the long COVID symptom or rather diseases. However, during the last slides, only the statistics for men were shown. So I wanted to find out what's the statistics of female developing long COVID. Question number 2, I wanted to find out how is the memory loss being treated as one of the symptoms of long COVID. The last one is just a bit divert. I wanted to find out how has been the statistics in terms of vaccine itself as the side effect, where there are stories like no, it reduces the infertility. What has been done? Any comment over the COVID-19 vaccine after now around 3 years? Are we seeing any other major side effect of these vaccines of COVID? I submit.
Thank you very much, Jackson. So, Dr. Yumbe, I'll repeat the questions. I got them all. And we'll also invite the panel of experts and doctors that have been managing long COVID patients. So number 1, he's asking about how in the presentation, there was a slide that spoke to females having a higher risk of developing long COVID, whereas during the slideshow and the presentation, most of the statistics that appeared were only addressing males. So I'll allow you to respond to the first one, then I'll repeat his third question, his second and third.
Right, thank you. In terms of male-female preponderance, the big thing is that with most rheumatological conditions, females are higher in the numbers. So meaning whether rheumatoid arthritis 3 times as much, with lupus, it can be 9, 10 times as much. So the people who we have traditionally been seeing have been mostly female. However, with long COVID, we must remember that it's an evolving pandemic or epidemic, because we have what was seen in the early years and we have now what is being seen now. The long COVID development, actually, even in the early years, was pretty evenly divided. If you saw the study on the inpatients, it was something like 53% men, which means that 47% were actually female. And then those were inpatients who were followed up at 6 months and 12 months. But with the surveys which were done over the phone, there may be some bias because of the population we had almost 80-something% who were female. So the method of information gathering might also affect the outcome. The subpopulation that information is being gathered from might observe the outcome. But as a rheumatology department, we have noticed that long COVID, we have been seeing a much more evenly split population than what we traditionally see from rheumatology, where more women are involved.
Okay. So the second question was, thank you very much, Dr. Yumbe. Jackson's second question was, how is memory loss being treated, seeing that it's one of the components of long COVID?
Okay.
Okay.
All right. So here am I stepping into the psychiatry area, but unless there's somebody who would like to take that question. So, okay.
Okay.
Yeah.
So Dr. Danielle will address that question. Yes, Dr. Danielle, you can introduce yourself.
Good afternoon. Oh, yes, good afternoon. I'm Dr. Danielle Ngamba, an IG registrar. So we had a session, I think last year or 2 years back, with our neurology specialist, Dr. Bachina Tromba, that actually have taken us through what are the potential causes of memory loss. So to address management, it's important for us to know what could be the cause. And the cause in this area were multifactorial. And among those causes, if I remember well, I'm inviting my colleague actually to chip in. There were multiple factors that were associated with inflammation, blood barrier block, but also nutritional, but also psychological factors, as the doctor actually have mentioned. So you need to actually have a broad spectrum of, if you need to thoroughly investigate your client to find a definitive management. This is why these individuals actually go through various tests like CT, like blood tests, actually, that could lead us to find the most likely causes of their memory loss, and then attend to those causes accordingly. So if there's a straight answer to your question, no, it has to go with case by case. Actually, it's a case by case management. Evaluate the individual appropriately, and then have a targeted management. I hope that could answer your question. Thank you.
Thank you very much, Dr. Daniel. So I'll allow any of the doctors that have been looking after patients in the long COVID clinic, as well as those that had acute COVID, to speak to what new side effects have they come across. And his main concern was the news that has been going around to say COVID vaccination actually can make you infertile. So how are we seeing patients that have been vaccinated with COVID and still bearing children, both male and female? Or is this something that you can speak to and confirm to say it's a real side effect? Then from that, you can also add on some of the experiences you've had in terms of side effects in patients that have been vaccinated. I'll allow Dr. Neil Naik to come through and give his contribution. So as we know, like any other intervention, there are always side effects. Like we know, all drugs have their own side effects, and much of this is actually seen in the post-marketing period, which is why data is still being collected. And I'll allow Dr. Neil to introduce himself and then speak to the question.
Yeah, thank you. Thanks for that question. And I think you've actually partially answered the question. And I'll ask also Mr. Kampamba, Dr. Namushi, to jump in if I am wrong. So with any vaccine, side effects are anticipated, and we actually attribute the side effects to a certain period. So within 42 days, you can attribute any effect to that vaccine delivery. So what's been commonly seen with the COVID vaccine, also dependent on the type, some were based on the viral vector, on the mRNA. So most commonly what's been seen is the vaccine-induced immune thrombocytopenia, that's development of clots before 42 days. Also from a neurological perspective, there's been high incidences. So this is an article that was published in the British Medical Journal that has Guillain-Barré syndrome, acute demyelinating encephalomyelitis as common side effects from the vaccine. But not very common, rare, but as has been recorded as a side effect of the vaccine. Yeah, and I think regarding the infertility issue, I don't think we've come across any of such literature. I'd have to refer back to yeah. If I don't know if you've ever come across them.
All right.
I don't think there is any data on infertility issue other than just a common.
We allow you to introduce yourself, and maybe you can join us so that the community may see you.
Don't worry.
Okay.
Yeah, so my name is Davis Kampamba, pharmacist from the Ministry of Health. So we haven't seen any effects in relation to infertility, except the common side effects that Dr. Naik has talked about. So there is no data so far, unless something that is coming out right now, because from the time that we have had COVID, from about 2021 to now, nothing recorded, but that does not mean that nothing will ever be recorded, because some of these things may start coming up after 5 years, 6 years, but so far, no record other than the common ones.
All right.
Yep.
Thank you very much, Mr. Kampamba. So there you have it. I think in as much as we've heard from the experts, we can also attest to say, like Dr. Neil addressed, some of these side effects do actually come about in the long term, but I think as we have seen with any other vaccine, it's a myth that is highly feared in the population to say whatever is injected in you may actually make you infertile. But I got vaccinated in 2021, received both doses of AstraZeneca, and I was actually just celebrating the birth of my newborn son this year. So I think on that aspect, well, I can safely say no, it does not make you sterile. Okay. Yes, I'll invite Mr. Kampamba back.
Sorry, so the fact that we have said there is nothing recorded, should anyone come with such a report, it's not now up to me to say this does not happen, so it cannot be associated. That's why pharmacovigilance is very important. We document and make a follow-up. Who knows? Zambia may be one of the first ones to record such and add up to the database. Thank you.
Thank you very much. All right, so we continue collecting data on long COVID, and I'll invite Dr. Namushi to give his contribution.
Good afternoon. Just to add one small component to it, if we got you right, the other aspect could be that could the vaccines also be contributing to what we are seeing or attributing to as long COVID? So really data has shown that actually vaccination actually prevents long COVID. So those people that are vaccinated actually at a lower risk of developing long COVID. So what we are seeing as long COVID actually could not be attributed to the vaccines. Every medicine, like Mr. Kampamba said, has side effects, but I think to attribute to effects 3 years, 4 years down the line to something that you received many years ago, that might not be attributed, or there is no relationship that could be made. However, like I said, COVID was a new disease, and we really don't know even just the side effects of the effects of long COVID itself. We have only had this experience for these few years, but we don't know what it will be like 10 years, 15 years, 20 years from today. But otherwise, all we can say is that the vaccines are safe and actually they prevent long COVID. Thank you.
Thank you very much, Dr. Namushi. So we remain vigilant in collecting data on COVID, the vaccination, and any new symptoms. And as we've seen in today's ECHO presentation, we have a combination of long COVID with rheumatological diseases. And in future, perhaps we should have a discussion with the gynecologist, as well as other specialties such as surgery, to speak to the effects of COVID in their practice. So thank you very much. Unfortunately, we do not have time for our repo. However, given the extensiveness of our presentation today, we can self-assess given the first pause that we had, and hopefully learning has taken place, and we encourage you to give us feedback so that we may improve in delivering these sessions to you. Thank you very much once again, and thank you very much, Dr. Yumbe, for the wonderful presentation.
Thank you. Signing off.